So now we're going to talk about using a bag valve mask. It takes practice to use a bag valve mask properly. So we will be practicing this in class, but it does take a lot of practice to use it effectively. So the first thing we're going to look at is the hand position. The American Heart Association suggests using what they call the EC clamp method, and this is where your thumb and first finger become the C, and it's on top of the mask as you see in the picture, and the E becomes the other three fingers. So with the C you are pushing down on the mask, and with the E you are squeezing the mask to the jaw and then opening the airway at the same time. And then you use the other hand to squeeze the ventilation bag. So breaths should be over 1 second. They should never be forced. They should be nice and easy. And we're just looking for chest rise. That's very important. Healthcare providers typically overventilate patients, and we're trying to get away from this because forcing air into the patient has several negative consequences, which we will probably talk about in the pathophysiology section and probably the respiratory and airway sections. So again, we're just putting in just enough air to get chest rise. Sometimes this can be, about half of a squeeze of a ventilation bag, assuming you've got a good seal on the mask. And that's why, again, this takes practice to get that seal good. You also may have elements that may not allow you to get a good seal, such as someone with a lot of facial hair, someone without their dentures in, or these sorts of things, or someone with facial trauma as well. Anytime you're doing CPR or airway ventilation or using airway adjuncts, you want to have your suction available. By the time someone begins to vomit, if they do, it usually is too late once they vomit, and then you recognize that and you have to go get your suction. Because if we give a breath with secretions or vomitus in the mouth, they're likely going to go down in the lungs. That causes all sorts of problems. It keeps the alveoli in the lungs from having the gas exchange between the oxygen and the carbon dioxide. And it also just plugs up airways where air just can't move back and forth. Some patients have had a stoma. This can be for a variety of reasons. It could be for some sort of cancer. It could have been for some type of injury to the upper airway, the face, but it's simply a surgical hole in the neck that goes down into the trachea. And these holes can be ventilated through. So as the picture on the left shows you, indicating where the stoma would be and what it looks like. And the picture on the right shows you ventilations through that stoma. You simply seal the mask around the stoma and give your breath as you normally would. And again, you see chest rise. One little difference is because of the size of the stoma, and it's small, although you would want to use your adult bag mask because you want that volume for the adult, you may want to use the pediatric child or infant mask, which were all of those fittings, those connections are all the same size. But you may want to use a smaller mask to be able to seal around that stoma a lot easier. There are patients that also, with a stoma, have a tracheostomy tube. And so again, this depends on why they have the stoma as to whether or not they'll have the trach tube. But this fitting on this trach tube, as you see here, will also fit your back mask. And we will, in our airway and respiratory sections, we'll talk about what happens if you have trach tubes that are plugged and by mucus or whatever, and how to handle those. But you can ventilate through a trach tube, and your bag mask without the mask connects right onto the front of this tube that then goes down into the stoma. So we're going to talk about two-person adult CPR. One of the things that I want to revisit is the American Heart Association's definitions of the age ranges. So an infant is from birth to 1, a child is from 1 to puberty, and an adult is puberty and above. And the American Heart Association defines puberty as any facial, body hair, arm hair on boys, or any breast development on girls. This should not be a long decision. Take a look at them and make a decision and then move on. If you're having to think about it and wonder, they're probably old enough to be treated as an adult. So, looking at two-person adult CPR, it's always preferable over one-person CPR to have 2 people or more. That at least gives you a chance to get a break every couple of minutes. Two-person CPR is less tiring. The one person isn't moving between the breaths and the compressions and the effort to give the breaths and the compressions both. Rescuers can switch every 2 minutes when they're tired. This is a key with high-quality CPR, that every 2 minutes we switch compressors, or when the compressor gets tired. So that is a key point with high-quality CPR. And 2 people can provide for better quality chest compressions as well. Again, with the one person not having to go back and forth between breaths and compressions, and then also by switching off, giving better high-quality compressions. So there are a variety of devices out there to assist in circulation. Here's a couple of them here, and they are in various stages of scientific research, but there is a concept out there that's called active compression decompression CPR. If you can think of a maybe like a toilet plunger, it's the same idea. This device on the left has a suction type device and is designed to give active compression by pushing down, and then also active decompression or release, as we would call it with manual CPR. It actually pulls the chest back up. So there is some good preliminary evidence to show that this may be helpful, but the real evidence is still out with this, and there's still a lot of research being done. On the right side of the picture, you see the impedance threshold device, which is a device that fits between your bag mask and either your endotracheal tube or a supraglottic airway. And through controlling the amount of air during the relaxation phase of breathing, through controlling the intrathoracic pressure, the impedance threshold device is able to give the patient better perfusion and better blood flow. So the impedance threshold device is a little more studied than the active compression decompression CPR, and there are a lot of places out there using this today, but there's still some research to be done on these to determine exactly how well they work and exactly how they work as well. So other devices that assist in circulation are the automated CPR devices. There are, shown here are the two primary devices in the U.S. There's a third one that I'll mention here in a second. The one on the left is the Zoll AutoPulse, which is a load distributing band CPR. So you can see that you have a short blue, what looks like a backboard, and a band, a disposable band that goes around the patient. And you see a control panel on the upper right corner of that board. And so this provides circumferential pressure to the patient during CPR. And again, you get automated CPR. It takes the element of getting tired out of it. Also, with all of these devices, you can move the patient and still provide high-quality CPR. So that's the benefit. The device on the right is the Physio Control Lucas 3 device, which is a mechanical piston device. So it works very similar to manual CPR. It has one point of contact and has a battery up on the top of the device. And so this device is fit the yellow short board at the bottom fits under the patient. The device then fits onto that board, and it provides that one point of contact with CPR. There's another device out there from Michigan Instruments. It's called the Thumper, and it's also a mechanical piston-driven device as well. These devices are is shown in areas where you cannot provide high-quality manual BLS, such as moving the patient, or maybe in rural areas where you have limited numbers of people to help. These devices are very helpful because they do provide that mechanical CPR. They're machines, they don't get tired. You have really good battery life on all of these devices. They are still under investigation with the scientific literature as to exactly how well over and above manual CPR they might provide compressions, or if they do. So the American Heart Association, in their 2015 guidelines, stated that if you could provide high-quality manual CPR by their definition, then you would not necessarily need these devices. However, they do provide high-quality compressions in the absence of enough people, and also when you're moving patients. So we're going to move on to infant and child CPR. Remember, a child is from 1 year old to puberty. An infant is from birth to 1. And it's important to remember that cardiac arrest in infants and children usually follow a respiratory event or respiratory arrest. So our goal is to prevent that cardiac arrest by treating that respiratory problem. So especially if we get to an infant or child that still has a pulse, our goal there is to maximize ventilations and ventilation and respiration so that we can prevent any ensuing cardiac arrest. So here's a few causes of infant and child respiratory problems. This is not an all-inclusive list. It's just several that we'll talk about throughout the EMT program. So you obviously have injury. So any injury to the chest, the abdomen, the face, neck, head could cause respiratory problems. There are a variety of infections, respiratory infections, and others that can cause respiratory issues. Foreign body obstruction is anything that is in the airway that's blocking it that is not supposed to be there, such as toys or food. So this is very common, especially in very young children, because they tend to crawl around the home and put things in their mouth. So this is why we try to keep, again, in the realm of preventing these problems, we try to keep small toys away from children that they can fit into their mouth. Submersion is also a cause of respiratory problems, obviously, submersion in water. And so swimming pools, lakes, ponds, streams, creeks, that sort of thing. So again, we try to prevent this when possible. Electrocution can also cause respiratory problems as well. Poisoning and overdose. Typically with infants and children, these are accidental poisonings, where really young children may crawl around the home and get into someone's medication, whether it's a high blood pressure medication or heart medication or a blood sugar medication or whatever. They can also get into other illicit drugs around the home as well and accidentally take those or be accidentally exposed. Sudden infant death syndrome or sudden unexplained infant death syndrome has been a problem for decades. And again, the older term here is sudden infant death syndrome. The newer term, which is supposed to describe the condition a little better, is sudden unexplained infant death syndrome. And so this is where an infant will typically be laid down to sleep or for a nap, and for some unexplained reason will die during that nap. And again, it's unknown as to why. It's why it's called sudden and unexplained. Autopsies typically do not find a reason for death other than cardiac arrest. Oftentimes, when SIDS or SUIDS, as the newer acronym is used, is found by parents or caregivers, many times it's too late. So again, we need to be able to determine, and we'll talk here later about when not to start CPR, but we need to determine, if this patient is viable or not. So going down through the process with infant and child CPR, very similar in some respects, and there are some differences to adult CPR. So we're going to determine unresponsiveness. Again, have someone call 911 and also get an AED. We're going to check for breathing and pulse, no more than 10 seconds. So all of this is all the same as an adult would be. So we're going to check breathing and pulse. For pulse on the infant, we're looking at the brachial artery. For a child, we're still using the carotid. And again, no more than 10 seconds. If there's no pulse and no breathing, we begin high-quality chest compressions. With one person, here's one of the differences between infant and child, or infant, child, and adult. With one person, we still do 30 to 2, so it's 30 compressions to 2 ventilations. However, with 2 people, we do 15 compressions to 2 ventilations on both the infant and the child. So that is a significant difference from the adult. If the patient has a pulse but is not breathing, we give 1 breath every 3 to 5 seconds. So this would be like with the adult, we call it rescue breathing. So this rescue breathing for the infant and child is 1 breath every 3 to 5 seconds.